My name is Paul Feuerstadt. I'm a physician, assistant clinical professor of medicine at the Yale University School of Medicine and an attending gastroenterologist at the PACT Gastroenterology Center in the Connecticut area. The name of the abstract is RBX2660 in the treatment of recurrent Clostridioides difficile infection, a subgroup analysis. Yeah, that's such an important question. C. difficile is just a major health threat in the United States right now. It's estimated that 500,000 people in the United States will test positive for C. difficile on an annual basis. And that leads to significant morbidity, mortality, as well as a burden on our healthcare system. So the question is, well, why is it so big? And the answer is, a lot of these patients that get C. difficile will recur. So it's estimated that up to 35% of all individuals who get treated for an initial episode of C. difficile, they will recur. And of those that recur twice, 65% will go on to recur after that. So they get caught in this cycle of recurrence after recurrence after recurrence. So why do they recur? We believe it's because they're being partially treated currently. There are two phases of C. difficile. One is the vegetative phase. The antimicrobials treat that. But the other is a spore phase that explains transmission from person to person, but also explains recurrence. That spore phase, after treatment with an antibiotic, stays in our gut, and it's up to our gut to eradicate it. But we know that the gut microbiota in patients with C. difficile is deranged or dysbiotic. So we have to naturally regrow what's deficient, and if we're not able to do that, that's why patients recur. So logic lives that what we've done over the last 20 years is we've taken a full consortium or a sample from a healthy individual that has all the microorganisms that we believe to be normal, and we've placed them in somebody who has C. difficile after the antimicrobial. What has that done? That potentially reduces recurrence in a significant way. And it's worked repeatedly through foundational trials, investigator-initiated studies. So what's the problem with investigator-initiated studies? Well, a transplant that happens in San Diego, California might be different than one that happens in Portland, Oregon, might be different than one that happens in New Haven, Connecticut, because the source is different and the processing is different. So what we as clinicians are looking for are consistent products. Products that have gone through consistent screening of the donor, consistent screening of the donor's stool samples, as well as quality metrics. Quality metrics including FDA overseen trials, phase 2 trials, phase 3 trials. And this is really the birth of microbiota-based live biotherapeutics, pharmaceutically produced products that have phase 2 and phase 3 data behind them that show consistent safety and efficacy. When we think about these microbiota-based live biotherapeutics, they come in several shapes and forms. One of them is RBX2660. This is an investigational microbiota-based live biotherapeutic that is given as a single rectal installation following a standard of care antimicrobial. The donors, these are human-derived, the donors go through comprehensive screening, the stool is checked comprehensively for pathogens, and there's quality assurance on the microbial consortium. Through a proprietary process, the samples are changed in a slight way to include just spore and non-spore forming bacteria, including Bacteroidetes. And this supplementation through 3 phase 2 trials and 2 phase 3 trials has shown recovery of the microbiota afterwards, as well as alteration in the metabolic environment associated with clinical outcomes, decreased recurrence, but also the basic science mechanisms that would explain decreasing recurrence. So what we presented here was a really exciting study, because what we did was we combined the phase 2 study, which was a dose-ranging study where patients had 2 or more recurrences of C. difficile, were all receiving standard of care antimicrobial and then randomized into either 2 doses of placebo a week apart, a dose of RBX2660 followed a week later by placebo, or 2 doses of RBX2660. So that was one study that was included. And then the other, as a result of that dose-ranging study, a single dose of RBX2660 proceeded to phase 3. And in that phase 3, all patients had 1 or more recurrence of C. difficile. They all received standard of care antimicrobial and then were randomized to either receive placebo or RBX2660, followed for 8 weeks for recurrence and 24 weeks or 6 months for safety. Due to the similarity of these trials, similar patient populations, same diagnostics, same follow-up, identical product, it was decided that we could do a pooled analysis looking at several subgroups, including age, gender, number of previous episodes, race, ethnicity, duration of antimicrobial prior to intervention, and finally, geographic site of application or geographic site of treatment. What we did was we compared odds ratios between these subgroups to see if they differed. And overall, we found no differences, which is exactly what our hypothesis was. There were no differences based upon any of the factors that I listed, basically stating to a clinician that yes, this works in a clinical sense from an efficacy standpoint in a broad trial, but when you look through these subgroups, you don't need to pigeonhole this group versus another group can receive this. The safety and efficacy should be consistent across those subgroups, so this can be broadly used in a general population. You know, as I stated, the most important finding is that there were no differences based upon age, gender, number of previous episodes, race, ethnicity, as well as duration of antimicrobial and site of geography. Also importantly within this analysis, we did do a combined pooled analysis for efficacy at 8 weeks. And that efficacy between the Punch CD2 trial and the Punch CD3 trial, including 221 patients who received RBX 2660, as well as 131 patients who received placebo, was 68.3% for RBX 2660 versus 55.0% in the placebo arm. Through chi-square analysis, that achieved statistical significance as well. For general healthcare providers, the significance of these findings is that yes, we see an overall efficacy of the product, but what we tried to do is tease through whether there was a sweet spot for this. Perhaps people over 65 might respond better than those less than 65. Maybe less than 14 days of vancomycin is better than more than 14 days of vancomycin. But what we showed is, regardless of the circumstance, demographics, treatment, number of previous episodes, this showed a very consistent efficacy. There were no differences in the odds ratios for treatment success, speaking to the fact that it makes it easier to know when to use this. You really can base it on the number of recurrences. What this really means for patient care with recurrent C. difficile infection is hopefully one of these microbiota-based live biotherapeutics gets an approval in the next 6 to 12 months. If it turns out to be RBX 2660, we know that there's safety, we know that there's efficacy through 3 phase 2 trials and 2 phase 3 trials. Now we know that this can be given broadly to almost any patient age 18 and over for their recurrent C. difficile infection following a standard of care antimicrobial. Makes it easier to understand when to use this. You know, for me, the most important takeaway is that this fits with all of the other clinical trials. Those 3 phase 2 trials, 2 phase 3 trials, 629 total patients being put through clinical trials considering RBX 2660. And once again, however you cut and look at the data, it's very consistently efficacious. It reduces rates of recurrence, but also it can be broadly applied, making it easier for healthcare practitioners to use this and understand, look, if you have a patient who has a first recurrence of C. difficile, based on FDA requirements, of course, you can say, wait a second, they're age over 65, they have recurrent urinary tract infections. If you have 2 risk factors for recurrence, this might be a great choice after you use a standard of care antimicrobial beforehand. It'll really cut down on that cycle, that vicious cycle that patients experience where they're fearful that this is going to come back again. The psychology behind this, treating the entire patient, really treating the entire infection also is important. And with a potential FDA approval, hopefully this will kind of round out our treatment algorithm. So this was a subgroup analysis, and it was set after the clinical trials were completed, and this was a pooled analysis across 2 clinical trials, the Punch CD2 and the Punch CD3. So what will be interesting to look at is, if there is an FDA approval, perhaps looking back retrospectively in much larger populations to reconfirm these results. I'm very confident in these results because the trials were well conducted and well overseen. but in a real-world population, it might be interesting to see what these results are. We do have RBX 2660 data in the real world, though. Under enforcement discretion, in the fall of 2021, our research group presented data looking at a cohort of patients that received this product who were not eligible for clinical trials or chose not to participate in clinical trials. Now, this was a retrospective analysis, and it was open label, but the overall efficacy was 82.8%. And that's, again, consistent with other clinical trials in an open label sense for this therapy when it's given after a standard of care antimicrobial. So once again, what we see is consistency of the data and consistency of the efficacy within multiple different environments. You know, it's such an exciting time in the microbiota-based live biotherapeutic world. Just at this conference, there were a couple of other analyses that considered RBX 2660. One of them looked at subgroups based upon severity of underlying disease. Super interesting topic. They looked at something called the Charlson Comorbidity Index, which rates the level of underlying disease. So how sick are you? 0 to 2, you're relatively healthy. 3 to 4, you have moderate disease. Greater than 5, you're pretty ill. They looked overall at 171 patients from the Punch CD3 trial who had mild disease, 71 who had moderate disease, and 84 who had severe disease. What did they find? What they found was with mild disease, the efficacy was 76.5%, moderate disease, 68.0%, and severe disease, 67.8%. The reason that I'm bringing this up is we see that with moderate and severe disease, it worked relatively consistently. So that's really exciting that this can be applicable to our more sick patients with multiple underlying medical comorbidities. Again, another idea of how we can apply this treatment potentially if there is FDA approval. We've been waiting years looking at phase 2, phase 3 clinical trials for these microbiota-based live biotherapeutic products. We've heard the data, we've seen the phase 2 trials, we've seen the phase 3 trials. We're now seeing kind of the runoff from that, other abstracts, etc. It is so exciting to be at this point because so many of us in this field have waited for this. We can see the light at that end of that tunnel. And we know that with an FDA approval, there will be a much broader population of patients who will have access to these treatments, but also providers who are comfortable using these treatments because there's FDA overseen data to support it. So really, the overall patient system will benefit from an FDA approval if and when that happens. And the burden of C. difficile hopefully will be reduced through education like this and communications like this, understanding what's available and then applying that knowledge.